Okay, welcome everyone to an exclusive PWN conversation about the 340B program. I'm so glad that you're here, and I'm going to start by sharing my screen and a video. I swear it's the second that I actually need the buttons that I lose them. Okay, here it comes. Wonderful.
In 1992, Congress struck a deal with pharmaceutical manufacturers to expand access to care and medication for more patients. If pharmaceutical manufacturers wanted to be included in Medicaid's coverage, they'd have to offer their products to outpatient entities, serving low-income patients at a discount. The idea was brilliantly simple. Drug manufacturers could have a guaranteed income from participation in the Medicaid program, and covered entities could have guaranteed access to discounted medications. Congress set up a payment system by way of rebates and discounts, affording certain healthcare providers a way to fund much-needed care to patients who could not otherwise afford it. This payment program is little known, but is now significantly large. It is the 340B drug pricing program. For nearly 3 decades, the 340B program has greatly expanded access to care and medication for underserved communities. But many public health advocates are asking how the program can be improved to serve even more patients. All public-private partnerships require transparency to instill confidence in the program. It brings us more accountability and more effective programs. Transparency helps to identify areas of improvement in operations or enforcement, as well as limiting waste, fraud, and abuse. Transparency in the 340B program ensures investments into patient access to care and medications for critically vulnerable populations and reaching patients. Accountability is often broadly discussed on a variety of levels about governmental and social issues, and the 340B drug pricing program is certainly no exception. The 340B program exists to address the healthcare needs of a segment of society, social needs. As such, program accountability is of paramount importance since patient health depends on it. These needs are often met through charity care. A cornerstone argument in favor of the 340B program centers on so-called charity care rates of participating disproportionate share hospitals, DSH. Those covered entities, specifically DSHs, should be able to leverage their 340B dollars to extend care and outpatient medications to offset losses from uncompensated care. In the ideal, offsetting the costs associated with charity care to provide more care to low-income patients is noble and moral and just, and an ideal society should support. The problem occurs when charity care doesn't match the needs of the community. The 340B program has witnessed explosive growth over the last decade, but unfortunately it hasn't always translated into greater access to care and medication. Contract pharmacies represent one of the largest areas of growth in the program, operating as middlemen, with their hands in the proverbial cookie jar. Since not all contract pharmacies adopt patient-first models of care, arguably, it would appear everyone is directly benefiting one way or another from the program and its lucrative revenue stream, except for patients. The 340B program has no doubt added benefit for patients and providers alike. The measure of this benefit, however, is shrouded by uncertainty over the lack of transparency and accountability, decline in hospital charity care, as well as the explosive middleman growth in contract pharmacies and pharmacy benefit managers. 29 years after the program's inception, it is now unclear to both regulators and patients, both qualitatively and quantitatively, if the congressional intent is being met.
I am a primary care physician.
Okay, and then from here, let me reshare. We have one more quick video we're going to watch to help ground us in the program. And there we go. All right.
I don't know if I can afford this medicine from the pharmacy. I'm already behind on all my other bills.
The 340B discount program was created to support nonprofit and safety net hospitals. but these hospitals are not helping patients.
Nonprofit hospitals were founded to help the poor. But a Times investigation has found that many are abandoning those patients in pursuit of profits.
Hospitals are profiting off of 340B.
But what about me?
But what about me?
What about me?
What about me?
340B. What about me?
Awesome. All right. Well, oh shoot, sorry. The video kept going. There we go. Okay. Well, thank you for that. I hope y'all caught some PWN members in that last video. It's very exciting. I'm going to pass it over to Brandon and Jen to kind of walk us through what those videos actually meant.
And Kelly, can you put up the slides for us too?
I can. Give me just 1 second to pull them up. If while I'm doing that, do you want to intro yourself?
Yeah, please. Brandon McSada. I serve as the CEO of the ADAP Advocacy Association. ADAP meaning Age Drug Assistance Program. I'm sure pretty much everyone, if not everyone, does know the ADAP acronym, but just in case. I have been serving as CEO since the organization's inception back in 2007. Wanda is one of my board members, longtime board member. Jen is also one of my board members. And I have been living with HIV since 2001, so I'm a long-term survivor. And public health, especially as it relates to our community, is something that I take very personally for obvious reasons. At one time, I was actually on ADAP for 5 months because I was in between jobs and I lost my insurance. So it's a very passionate issue for me for personal reasons as well. So with that, and I'm proud papa of Sebastian, who some of you got to meet. I work for him full time.
I mean, who doesn't want to work for Sebastian full time? Like, he's adorable and polite and lovely. And you're doing a great job, Papa man. I'm Jen Laws, CEO of Community Access National Network, or CAN. And 340B has been on our radar for quite some time. About me, I'm a transgender guy. I live out in rural Louisiana, well, suburban Louisiana outside of New Orleans. And I was diagnosed with HIV in 2004. This space is super, super important to me. And having this opportunity to present this issue, 340B, as an issue within a broad spectrum of HIV stuff, is to PWN is kind of cool. I'm really grateful that we've got this opportunity to talk with y'all. And as we go through this presentation, we do our best to point out when we have an opinion versus where there's something objective and factual. We are not here to try and inform any positions that y'all might take as an organization or as individuals. But we do think that this issue is kind of important, especially when we're talking to the tune of $110 billion. And what that means for patients, or what it should mean, at least in our perspective.
Thank you, Brandon and Jen. I will go ahead and share, just so you know, I have a PDF of the slides, so it might look a little weird, but I think it'll still work.
And Kelly, I'll just say next slide when we can advance.
Perfect. That sounds great.
So we can advance. Next slide. The first video, the digital video, kind of gives you a very broad overview of 340B. But I think if you were to go out and ask most HIV advocates, what do you think about 340B? They'd probably look at you like you were nuts. In fact, there's a long-term advocate who is one of the most knowledgeable advocates that I know in long-term care for long-term survivors. He came to a meeting that we hosted some years ago, and he saw 340B on the agenda, and he actually thought it was related to some sort of 420 marijuana access. So for someone as knowledgeable as him to think that that's where this conversation was going, I thought was comical in one way, but also told me that we had a lot of work to do to educate patients on 340B because this really does impact us as patients. The law was created in 1992. When the video talks about Congress striking a deal, pharma companies wanted to sell their drugs in Medicaid, and they wanted to do so in a way that would naturally make them money. They're businesses, they're in the business to make money. So the federal government squeezed them and said, okay, fair, but to do so, you have to offer these drugs at a discounted price to entities that are providing care to indigent populations. And the 340B is named after the section of the law, and it falls under the Public Health Services Act. Okay, so that's where that 340B the name comes from. The entities, the term that we use are covered entities. That means that they are covered under the program. They have to be deemed eligible to participate. There's a whole set of criteria. When the law was first passed, it was very exclusive to hospitals, and some other entities. And then as the years grew, it grew into Ryan White clinics, hemophilia centers, other community-based organizations. And the thought was, if these organizations are providing care to people who need it in their community, that they should be able to benefit from this program. So basically, and I'm going to let Jen get into the logistics, the nuts and bolts of how the program works. But I think that gives you a general sense of what is the law and how it works. With that, I'm going to stop, because I want to answer any questions that people may have based on from the first video, the primer about what is 340B, and this quick snapshot that I've just kind of reviewed about 340B, when it started, what it's designed to do, who's eligible. And if there are no questions, we can move on, but I want to make sure that we don't lose anybody early on here. Okay. Next slide, please. So some of the is there a question?
No, it's just me.
Oh. Some of the covered entities are federally qualified health centers, FQHCs, Ryan White clinics. So your provider could very well be participating in 340B. Hemophilia treatment centers, disproportionate share hospitals. The video kept referring to them as DSH hospitals. And this is one of those things where you can edit a video 100 times and something slips by you. And to this day, it drives me nuts, because the way we refer to disproportionate share hospitals is dish hospitals. Okay, so just think of a dish that you would eat off of. So if you hear somebody say dish, that's what they're referring to as a disproportionate share hospital. And a dish hospital is a hospital that the disproportionate number of their clients, patients, are people who are lower income and need some sort of help. Okay, contract pharmacies, and contract pharmacies could be just about anything, and this is one of the areas that reform comes into play. Family planning centers, cancer treatment centers, and children's hospitals. Excuse me. I want to stop again. Any questions? Sebastian. Opposite is meeting, okay.
I have a question, if that's okay.
Yes.
Cool. So I see you were saying that this kind of speaks to reform. Clearly, the program has been reformed if folks were added to it, right?
I don't know if it's necessarily reformed, as in it has continually been expanded. There has been I shouldn't say there's been very little change in terms of the original language of the law. There's been expansions that have happened over time. And one of the things, there have been attempts to maybe go through the regulatory route. Those never really seemed to go anywhere. There was one, it was called the mega guidance, because the package of regulations was so big, it was so comprehensive, and it never went anywhere. So it's more, look at it more from the lens of the program was expanded versus reformed. I will note one thing: there is no government money spent on 340B. Okay, this is a program that is funded solely through pharmaceutical drug sales and the rebates from those sales. Okay, so when you hear that it's a program, you kind of maybe think in your head it's Medicaid, it's Medicare, it's Veterans Affairs, it's Ryan White. It is a pharmaceutical funded program. Okay, so and then in the form of the rebates that go back to providers.
Well, and there's
I'm
some
gonna. Okay, I was
pushback
just gonna
on
say
that.
I'm gonna pause and let Jen.
So I say there's some pushback on that because there's tons of lawsuits that happen around 340B. There's tons of argument that happens around 340B, and lots of states are getting their fingers into this. So there's dollars in this program that come from government entities, but they're not in a way that actually serves the program. And there are no dollars that come out of the program for things like oversight, right? Those things are funded through taxpayer dollars. And when a state action, for example, is challenged by AHF, I'm going to throw them out there. AHF refused to open its 340B books to the city and parish of Baton Rouge a number of years ago, and they closed their contract as a result. And then AHF sued them, and the state and the city parish had to spend dollars related to this issue. At the core of it is 340B. So there are government dollars around this. But in terms of when I say 110 billion with a capital B, those are pharmaceutical dollars that are put in there. They're coming out of manufacturers' pockets. And that's not to say that they're not making plenty of money. It's that the deal that was struck is that if we're going to give you room to make a ton of money, then you're going to give this drug away essentially for free or in a way that expands service and care. When 340B was instituted originally in 1992, there were only about 12 hospitals in the entire country that would qualify. Now, as of January 2023, more than 2,600 hospital entities qualify. So when we talk about the expansion of the program, and that's just hospitals, right? We talk about expansion of the program, who's figured out how to put their fingers into it. We're talking about this really kind of massive explosion that we're not seeing a whole lot of benefit for patients. And I do want to point out that what qualifies a disproportionate share hospital or a DSH is only a little more than 11% of patients being on Medicaid. 11% of patients in that area, not even particular to the number of people the hospital is serving, but in that area. And when we think about Medicaid expansion, for example, 11% is not a lot. Should I go?
Next slide, please.
Is that my turn?
No, next slide.
Oh, I think I see Wanda's hand. No question, Wanda?
Yes, I do have a question. I'm trying to get it worded right in my head. Okay, it's because it's kind of two things. Okay, the dish hospitals and things, does it necessarily follow that persons have to be on Medicaid, or is it people that live, in the poverty neck of the woods?
In terms of what qualifies a disproportionate share hospital? Yeah, yes. It's the area. It's the geographic service area around the hospital. It is not necessarily who the hospital is actually serving.
Okay.
So when we think about how, and this program is, the patient definition is one of those super wonky pieces about this that is
right.
in a mess right now. So when we think about how this is done, I would hope that we have all been so active in our communities that we know that patients in highly impoverished areas are going to hospitals and walking away with a boatload of medical debt. So if this hospital is supposed to be serving this community with literally millions of dollars from 340B, and that's absent any other grants they're receiving or anything else, why are patients walking away with this kind of debt or afraid to go to the hospital because of that debt?
Okay. The other question that I had is, we know that this program is in place as a safety net, that these folks agreed to this program, to participate in this program. Where is the money being banked?
Excellent question.
Why don't we hold off on answering that, because we're gonna before I hand this over to Jen, I want to give credit to where credit's due on this chart, which we used in the video. This is done by Drug Channels, Dr. Adam Fine. if you are wonky and you want to learn stuff about drug pricing, 340B, rebates, all that stuff, you should sign up for his listserv. I'm pretty sure it's free. Adam can take some of the most complex things and put them into little charts like this that actually make sense. So Jen is going to talk to you, going to give you a 32,000 foot view of how the program works or supposed to work.
Next slide, please. And I know that chart's a little funky, and it should be super simplified, but the reality is that the drug supply chain and the dollars within it is really kind of complicated. And the more complicated it gets, the more different entities have figured out how to put their fingers into it and extract dollars for their benefit, which I can't fault anybody for doing in a capitalist society. But at the end of the day, that channel is supposed to serve us. So you're starting to see where my opinion comes in on things. I have very strong opinions about this. So the way how the program's supposed to work, as we talk about allowable use of those dollars, those rebates coming back in, things like that. So, versus how it's actually working. The way it's supposed to work, covered entities earn rebates, and it's supposed to help their bottom line. Their actual operating costs kind of balance things out when people can't pay, right? And especially with the idea of your provider might be purchasing your medication for you to get it to you instead of having to go to an outside pharmacy. Or when you're dealing with provider-administered medications like cabotegravir. So hospitals, the way that in theory, one of the ways in theory it would work for them isn't necessarily that reduced or discounted medication, but it might be you not getting a bill at all afterwards, or applying for financial assistance or what we call charity care. Now, hospitals have done some really funny tricks with that, but under the Affordable Care Act, each hospital who is qualified as a nonprofit in order to qualify into the 340B program must have a financial assistance program. But there aren't any requirements as to what those programs are supposed to look like or how accessible they're supposed to be. 340B rebates are supposed to be directed toward patient care for some clinics, especially when we think about federally qualified health centers where there's not, the mandate is to provide care regardless of ability to pay. They're not necessarily free clinics, and they might have collections policies or sliding scale policies, but this kind of helps blunt the actual cost of providing that care to impoverished communities. And some of these FQHCs have done astounding work with their 340B dollars. They've opened up medical clinic or mobile clinics. They might have out of office emergency or tertiary care, and they might offer reduced or free cost prescriptions as ordered through their own piece of things. Broadly, the idea is supposed to make healthcare more affordable. Now, this is where we're starting to see some of the problems, and there's a lot of Gen opinion in a bunch of this. Under, let's say that $110 billion, that's what pharmaceutical manufacturers reported as their 340B sales. It's the overall sales, what was charged under this program by parties, including themselves. And then $54 billion of that was given back to these entities. Well, kind of passed through, but not necessarily the entities. You might have a pharmacy benefit manager that decides to take a carve off some of that rebate piece in order to keep the drug on the formulary. Or you might have a pharmacy that needs to take a dispensing fee, but they don't have a solid contract that caps that dispensing fee, which we had an Office of the Inspector General report in 2018 showed that one contract pharmacy, one egregious instance of a contract pharmacy charging $2,700 as a dispensing fee for hepatitis C medication in the 340B program. That's $2,700 that an FQHC did not receive in order to extend care to a patient. Hospital charity care rates are declining. We have tracked this steadily for years. Last year, hospitals issued more than $16 billion in medical debt across the country, and that exceeded just their tax write-off size, much less all of these other dollars coming in through the 340B rebate program. So you're starting to see some of these problems on how it's actually working. There's some major concerns on how 340B revenues might be helping to pay for hospital administrators or executive salaries. When we think about those huge salaries, one, again, an egregious example is Children's Hospital of Philadelphia. There's a massive cover story that happened where they paid their executive, their CEO, more in money, $7 million more than what they give out in charity care. They issued more medical debt than that. This is a massive problem when we start thinking about what the enterprise is for these hospitals, and that's to serve impoverished patients. So there's another piece to this, and it's something that we don't have a whole lot of insight into when we talk about a lack of transparency, is we've got really good evidence that hospital systems, those large hospital systems, might be using these dollars to buy out primary care providers in the area, reduce compensation, and consolidate care. This is particularly important when we look at majority minority cities like New Orleans. Tulane is selling University Medical Center to a different hospital entity, and they're gonna close down University Medical Center. It might have a standalone emergency room, it might not, but there were millions of dollars in federal grants that went to this. It is a 340B entity as it is right now, and what they're gonna do is consolidate care to more white areas of the community out in Metairie. This isn't the first time we've seen it. Indeed, Bon Secours out in Virginia had a massive New York Times investigation into how they were funneling these dollars away from impoverished Black and brown communities. We're not going to lie about that one, to whiter, richer suburban areas to buy out things like liposuction clinics. So there's problems with how we're seeing these dollars flow, or how we're not seeing these dollars flow, because we have no transparency. So like I said, the medical debt thing is exploding. Patients face these issues day in and day out. There are people who avoid seeking care they need because they're afraid of what that bill is going to do to them. And we know that this debt collection piece can get really aggressive. We've seen folks have their homes leveraged against them. We've seen folks not have a collection come against them that they can't go rent, or they can't get a loan, and an auto loan. This is problematic when we talk about how much money these entities are receiving and what kind of benefit they are or are not giving to their communities. Yes, Kelly.
This is wild. Thank you for sharing this. I'm wondering if you can give me just a high level understanding of okay, so funding comes from pharma, and then it goes to these covered entities to pay for some amount of medication so that it can be offered at low or no cost to folks who need it. Is that the flow?
Sort of. So a patient comes into a 340B covered entity and says, I need care, and that's going to include this medication, and or is determined to be a medication that's covered under 340B. Now, that entity may purchase that medication, or they may have a contract pharmacy purchase that medication on, like they have a contract with a pharmacy. That's why it's called contract pharmacy, to purchase that medication. That patient's reimbursement rate for that medication, whether it's through Medicaid or whether it's through private insurers, is going to be X amount of dollars, and it might be huge, right? So when we see it in certain insulins, it's anywhere between $300 to $500, right, per fill. Now, ultimately, those insulins, when the rebate comes back in, they cost that entity a penny because they can't charge less than that legally. But that's how large that rebate is. And this is kind of big because the IRA sat there and said, hey, we're going to do this amazing thing and cap insulin cost at $35. And everybody said, yay. But that makes up about 10% of FQHC funding. And now they're getting $8 instead of $300 to $500 per fill. There are flows and trade-offs. And there is a massive ethical discussion about how 340B may or may not be inflating drug prices in this country, but that's not what we're talking about tonight. So next slide. Our big thing is charity care. Because hospitals, so FQHCs have to, under their federal grant. Every penny that goes in and out of an FQHC is tightly scrutinized under a federal grant. We have zero problem with most FQHCs, not all, but most FQHCs when it comes to these things. Some FQHCs have kind of figured out how to game the system, and are flubbing things and don't have appropriate oversight, but we can get around that. Like they're not my biggest issue. The hospitals are. And the way the hospitals are meant to realize their 340B savings, or those revenues if they do it, is supposed to be to pass on charity care. So when we talk about charity care decreasing, when we see nearly 20% of the country has medical debt in their credit reports, when we see aggressive policies like doctors and hospitals and administrators getting kickbacks for signing people up for care credit, and that removes those medical debt protections, what limited ones we have, there's a big concern. So in 2020, Osher, which is the largest hospital system in Louisiana, issued more than $110 million in medical debt against the community it's meant to serve. But they had more than $580 million in carryover dollars. They could have covered every last penny of bad debt they pushed against this community and still had $470 million to carry over for next year. This is a big deal. $140 billion weighing on the backs of communities. It scares people away from getting the care they need and asking for the help that we need. It keeps people out of care. It interrupts care left and right, and especially when we're talking about lost care situations and people living with HIV. We're talking about what harms our community. So charity care is really very concerning for us. And that rate's fallen over and over and over again. Now, what's super interesting is hospitals not participating in the 340B program across the spectrum, not every hospital, but across the spectrum in aggregate, often offer more charity care than hospitals participating in the program. And that's really kind of concerning. Next slide, please. So, who stole the cookie from the cookie jar? There's a couple other bad actors in this space, and when I say bad actor, I'm talking about my opinion, right? But they are in this space, and that is an objective fact, and that includes pharmacy benefit managers. So health insurers would kind of operate as a middleman, and we know that in our own care, right? And they do this thing as part of their fee collection called rebate retention. It means they're keeping a giant chunk of dollars for negotiating lower rates, but there's no negotiated lower rate in 340B. That already happened. So why are they keeping anything? Hell of a thing. So, and especially when that looks like patient steering to particular pharmacies, right? And especially if that pharmacy is a big 3-letter pharmacy, maybe listed on this page, because that's the pharmacy benefit manager steering them in order to collect more in the dispensing fee and the rebate. Now you're seeing where more and more dollars keep coming out of this program, and they're not to patients. Next slide, please. And I'll let Brandon take it from here.
If you go back to the digital video and talked about in 2000, it was that chart that was, showing as the years went on how the program was growing. In 2020, the revenue under 340B was $38 billion. Fast forward 3 years, $54 billion. So there is more and more money going into this program, and that's relevant if you compare it to the numbers that Jen was sharing about medical debt. If we're looking at $20 billion more going to hospitals, going to grantees, why then are we seeing this skyrocketing growth? For reasons like that, we launched the 340B project in 2022, and it was to raise awareness about 340B, why it is important. And I will make a very strong statement that 340B has been a lifeline for Ryan White clinics. A lot of these clinics, it's been the difference between keeping their doors open and closing them. The lion's share of grantees under the Ryan White program are not bad actors. And when I say the majority, the vast majority, they're trying to make ends meet. They're trying to provide services to the people in their community. They have patients on their boards. many of the staff are people living with HIV, but there are, like hospitals, there are bad actors. So whereas if you compare the Ryan White grantees and some other grantees against hospitals, they're doing much better, but there is still room for reform. There's always room for reform. So we decided to appoint a patient advisory committee, and rather than load it up with experts on 340B, we recruited patients who knew little or nothing about 340B. And we went to pharmaceutical drug manufacturers and asked them for money and said, we want to educate these people. And with the understanding that we were going to bring in people from all stakeholder groups who may have different opinions. And that it was a very clear message that we sent to the pharmaceutical companies, that you will have no editorial control over what goes on in these meetings and the information that's presented to them. And now this gets to my opinion. And I did say to them that I think overall, though we may not agree on everything within 340B and 340B reform, if you add up the overall picture, I think there will be a lot of alignment between what pharmaceutical manufacturers want to see changed and what patients would want to see changed. And they said, yes, we're in. And they gave us money and they left us alone. And for the last year, we convened 5 meetings and brought in we brought in researchers. We brought in, Jen was our very first content expert. And so he kind of gave the 32,000 foot overview of 340B, but we brought in experts who presented information to the advisory board members. They were able to digest it, get into give and take Q&As with them. We had follow-up conversations with them. We're constantly throwing information, reports their way for them to read. And what we're seeing is that they're taking this information and going back to their communities. So a lot of these folks either serve on Ryan White planning councils, they serve on boards of their local community ASO, maybe a mayor's committee on HIV/AIDS. Many of them have a social media presence, so they're sharing information. And really what they have been able to do is connect the dots. How come 340B revenues are going up? How come executive compensation is going up? And I'm gonna stop there and I'm gonna read something to you if you'll let me, because we've been doing a investigative research project on 340B revenues, executive compensation, charity care, and medical debt. And we at first selected 20 hospitals and 10 Ryan White grantees. According to the ones that we selected, executive for the organizations that were, what we did is we looked at what did the organization look like before they became 340B eligible, and then what they looked like following year, 5 years later, 10 years later, most recent year. Across non-hospital grantees, so this would be Ryan White clinics, your ASO, executive compensation increased at an average rate of 391.3%. When you exclude the outliers, and there are a few big outliers, the average was still 320% increase on average of executive compensation working at these organizations. For hospitals, the CEO compensation increased at an average of 225%. If you take out the outliers, you're looking at 186%. At the same time, so you see the revenues going up, you see the executive compensation going up, and then you see this charity care going down. And again, the charity care only applies to hospitals. It does not apply to the Ryan White grantees, your ASO, only applies to hospitals. But nonetheless, there's a hospital in every community. And Jen outlined, the medical debt that's being issued. And then you look at the percentage of medical debt that's going on. And I can tell you our advisory committee, if I had to summarize in one word, is pissed. They've connected the dots and they're saying, what in the heck is going on? Because the reality is every single one of our members of our advisory committee either owns medical debt themselves or knows somebody personally, family, friend, colleague, whatever. So moving forward into this year, we are expanding our advisory committee members. We have recruited 10 new advocates. Most of the folks on the advisory committee are HIV positive, though not exclusively. We have some cancer survivors and other chronic health conditions. But this is something that we are really invested in because we recognize the importance that this program plays in our community, in our space. But at the same time, it could be doing so much more if organizations weren't spending the money the way some of them are spending it. And I will use an example. I had a pretty serious thyroid issue going on over the summer. So I was constantly going to Yale New Haven Hospital here, which is the big gun up in this neck of the woods in Connecticut. And in the wall, in the center the cancer center that I had to go into for some testing, embedded in the wall was a water fountain. Okay, not like just attached to the wall. It was literally embedded into the concrete structure of the wall. Where do you think they got the money to put that beautiful water fountain in the lobby of this cancer center? I don't have facts to say because they don't have to tell us where 340B revenue goes. Okay, where they're spending this money. But if I were a betting man, they use 340B rebate dollars to build this monstrosity of a water fountain. I was texting Jen as I sat there in that waiting room, saying, he's like, take a video. So these are the types of things why we get so worked up and are really engaged on this issue. And I will stop and turn it over to Jen because Can is doing quite a bit in this space as well.
So I see your question in the chat, and I will answer that momentarily. I will tell you that one of the most famous lines somebody referenced around this was, "Why do you need to rob a bank when you've got 340B?" They don't have to disclose how they're using those funds because, as a nonprofit, that's not part of their requirements. There are no reporting requirements for dish hospitals or dishes in this space. And it's one of the things that we would like when we talk about reform. That's one of the things that we personally want to see. It's something that we've heard back from ADAP's patient group. And I will tell you, one of the coolest things about ADAP Association's patient group is they got to sit down with the manufacturers participating in this project and talk about what they wanted to see from the program. And I'm going to tell you, the follow-up that Brandon got from that was constant. Okay, so we heard this idea. How do we integrate that? Okay, we're not giant fans of this one thing, but what if we adjust it this way? Is there a middle ground that we can get agreement on? The manufacturers participating in this program, and at least with regard to the outreach and education that we're doing, are interested in hearing from patients on how these dollars need to be spent. It is not Can's position that these dollars cannot be reinvested in things like care labor, paying for nurses. I just don't want to see it going into an executive's pocket. I want to see people being taken care of. So in 2019, Can issued a 340B reform commission and kind of did a comprehensive report talk about where these things, where there's room to really kind of increase that oversight and make the program function the way it's really kind of supposed to if it's going to be serving communities. In 2021, we launched our 6-part educational series. There's 6 blogs. They're really intense. They're wonky as all get out, but I have done my best with those to make them tangible and understandable. At the end of the day, I didn't graduate high school or college. I am self-educated in this space, and it's because I've got a passion that says that we should feel empowered to engage our communities and these policies affecting our daily lives as patients. And then in 2022, we released a video kind of summarizing the project, and you guys got to see that at the beginning of the presentation here. And this last year, we got to move through the What About Me campaign. We're putting that patient voice first. I did see somebody with a hand up, and I'm not, is it Grace?
Yes.
What's up?
I just wanted to refer to the last slip that I really agree with you in terms of non-compliance of the 340B program, because I was a community health worker for about 5 years, and I was accompanying patients, to hospitals for their procedures, to pick their medications. I was picking their medications from the pharmacies and taking to their homes. And there were some unfortunate incidents where I would go to the pharmacy after the patient had been discharged. There would be no medications. And I would go, when I finally got the medication, I would go and find the patient had died in the house alone and nobody even knew about it. And I know that Caldas had a member listening session in 2018 where there was a non-compliance discount bill of 8.5 billion that the 340B program could not discount for $8.5 billion. And we could not even get transportation for patients who had procedures to be taken home. So here we were sometimes stopping cabs on the streets to take a patient who had a surgery home. So I'm quite interested in how this can be made to work out and how they can be made accountable. And then we are having all these 5-star pharmacies that look like 5-star hotels, yet we as persons living with HIV cannot accept basic medication like ibuprofen.
Mm-hmm.
Yeah, I just wanted to comment on that.
Absolutely. These are all concerns that are coming up. And I'm going to tell you right now, last Friday, not this last Friday, the Friday before, the Gang of Six senators kind of dug into 340B and offered language on reform. And not all of it's great. Some of it is really great. It's called Sustain, and we can send a link to you guys on that. I'm going to ask Kelly if we can move to the next slide, because it says, how can PWN help? And here's the deal. We don't have a solid ask for you. We have zero solid ask on this. Rather, we wanted to provide information in an educational way, clearly plenty of our opinion, that says this might be an issue you want to care about. Reform's coming up, and we're not going to see reform geared toward patients if patients aren't engaged. So we're not asking you to take any particular position, but if there is room, there is interest in the PWN membership to take a position, if there's additional education we can offer, if you want us to help form some of that through sitting down and writing for you, absolutely. We're more than happy to offer that. At the end of the day, CAN and ADAP Advocacy work for our communities. We want to work for you.
And keep in mind, if this is something you do decide as an organization and the members decide they want to become more familiar with and educated on and involved in and issuing statements, if you have a take on something that is different than ADAP Advocacy or CAN, that's okay too, because the difference is it was patients who made that conclusion. There are lots of coalitions out in this advocacy world right now. Both ADAP Advocacy and CAN belong to one that is a coalition of pharma companies, community health centers, and patient groups, okay? But there are many, there's a contract pharmacy coalition, there's a Ryan White Clinics coalition. If you look at all those other coalitions, none of them have a patient serving on their board. None of them have a patient serving on their legislative affairs policy committee, okay? So you have all these groups who are claiming that they want this or don't want that for 340B because it's in the patient's best interest, but they have no patient involvement.
Well,
everything we are doing
patient involvement. They're paying people $600 to go have a wave a flag around and all of that, but there's not authentic engagement. Olga, I see your hand up.
Yeah, so what you're talking about, I remember in Ohio, a few years before COVID, we used to have a coalition for Ryan White care and prevention, two separate ones. And we used to talk about the formularies and the rebates and all that the pharmacies were getting and the estimates. And I remember AHF, in fact, I was at a hearing about how they're doing, drug pricing with other clients and stuff like that. It was, oh my God, it was a big case here in Ohio and almost led to the waiting list of our meds. Because I testified in it, if it would go to a waiting list and stuff, and the rebates and how they're not really being used the way they're supposed to be used for the patients. But after our coalition went into both meeting at the same time, we kind of lost track Ohio kind of lost track what was going on with this. It's been now maybe about 5-7 years. that I've heard anything about this, but I remember all this going on way back when and when it started. Because Ohio was really fighting. Two different agencies were fighting whether to do rebates and not to do rebates. Big, CEOs. And I'm just wondering now, being that there's nothing no more in Ohio that I know being talked of, how can I get involved?
Thank you for that. And we hear that quite regularly. And one of the things that we would like to be able to do for you is be a resource to provide you with links to how do you get involved. And it's the series, the 6-part blog and infographic series that Jen talked about. He and I were involved in that, and we really tried to approach it from a patient perspective. So I think there's things that we can do, and I can follow up from our meeting with an email to Kelly with some links to not only information, but links to what are potential ways to get involved. Because I think this is one of the things that we need to be able to continually do is get more patients involved in this conversation, because these dollars are supposed to be helping us.
Yeah, because this is what originally got me not liked in Youngstown.
Yeah.
Especially with our clinics and stuff and our clinic funding. They did not like me at all. They try to hide all information from me about what was going on in Ohio. And it feels like if anything's going on in Ohio, they have hid everything from me now because of how involved I used to be in this and saying how this was not being used right.
Kelly, so I will follow up with you and maybe give you some of this information, and that way if you all have a conversation and decide you would like to move forward or how you want to move forward, we can certainly help with that. But I want to just say on behalf of Jen and I, thank you for your time on this. We hope it opens raised some eyebrows and kind of got some blood pressure going, because we definitely would like to get more of you involved in this. But again, we're not here to ask for anything of PWN or ask for you to take a stand or do whatever. The only thing we do ask is just take a look at it, because I think you'll probably come down like where our advisory committee came down on. The more they looked into it, the more they learned about it, the more they got pissed, and now they're very involved. So we have our contact information here. Encourage you to, even you don't have to go through Kelly, you can just reach out to us individually. We're always on our phones and we're always checking our emails, so we will definitely get back to you. But thank you, Kelly. Thank you so much for putting this together, and I hope everyone has a wonderful evening.
Thank you so much. So you made this very, very easy. Thank you for all of the amazing content that you produced for everyone. I see Melanie has a hand. Can we field one more question?
Yes.
Okay, go ahead, Melanie.
Okay, in the last year and a half, I've been hearing quite a lot about 340B and how in New York, for instance, 340B was used for direct services to patients, and that was going to be stopping, and they were going to be redirecting that money. I live in Maryland, and 340B used to be, the rebates went to MADAP, which is Maryland AIDS Drug Assistance Program. And the rebates, they would get that, and it would lower the cost of medications, so they said. And then they would bank some of that money to use for community-based organizations to get funds to use for their programs. Well, HRSA came in and told them they can't bank those funds, they have to spend them. So now in Maryland, the rebates that used to go to the state, now community-based, FQHCs, pharmacies, they're their own 340B rebates. And so half of the money that the state used to get now goes somewhere else. And so they told us this year that they're going to have to lay off staff, and they're going to have to stop their mini grants to community-based organizations. And so I'm just saying we need more information on this 340B stuff, because what I surmise on my own, and then after hearing what you said, that schematic diagram makes absolutely no sense to me. It's making it more difficult to understand, to follow where that money's going. I need to be involved because as an older woman living with HIV, I want to know more about who's diverting funds from where, because they're trying to reduce or eliminate funding for people living with HIV. And I am more than pissed.
I'm going to let you have the last word because I have to go back to my other job with my boss over here. Because that's, if you notice the language used in CAN's new awareness campaign, 340B, what about me? I mean, that's exactly where this concept came for this campaign, was everybody's getting all this stuff, all this money, all this growth, all this expansion, but yet what was the original intent is not happening. And unfortunately, some of the groups, there are groups who are fighting this. And when you look at these dollars and the fact that you can't trace the dollars, you don't know how they're spending it. Why do you think they're fighting reform? They don't have patients on their boards. They don't have patients on their policy committees. This is the perfect example of an entity looking out for its bottom line, its self-interest, its pocketbook, its wallet, and not the patients. And that's not saying that they're still not helping patients, but they should be doing more for that. So, Kelly, I will follow up with you. We can give you all the information you need, or water. You just let us know what you need from us, and we will gladly assist.
Okay, wonderful. Thank you, Brandon. Thank you, Jen.
Thank you.
And I hope y'all have a good night.